Welcome to the World Congress of Cardiometabolic Medicine 2019 held in Mumbai. I'm honored and rather pleasantly honored to have none other than Drs. Ulhas Pandurangi with me talking about the electrophysiology. Well, I must summarize you a few big things. I myself is an electrophysiologist by trade, and if you have someone who's from the same field and same faculty, it's really an honor for me. I would like to describe him as a king of the electrophysiology from the south of the India. He's a director of EP and pacing at Madras Medical Mission Hospital, Chennai. And he has done plenty of complicated procedures on electrophysiology. Welcome, Dr. Ulhas.
So Dr. Ashok, I too am honored to be with you, and I'm sure it's a great company you are going to give me to discuss, one of those complicated areas of interventional electrophysiology.
That's very true, very, very true. Actually, we have been hearing about electrophysiology was considered as relatively new field in India. But lately, I'm seeing that it's a robust evolvement just because of the people like you have worked very hard to establish and make the firm's feet on ground for the electrophysiology. Tell us a little bit more about your experience in EP in southern India.
Yeah. So as you said, it was about 2 decades back. Electrophysiology was in its nascent stage. But then there is such a tremendous growing interest in the field of electrophysiology that in the last 2-3 years, there has been an exponential increase in the number of cardiologists who are actively practicing electrophysiology in the country. So when it started out, say, about 15 years, 20 years back with just about 8 to 10 people, now we can claim that there are at least 200 people who are actively.
Really?
Yeah. So I think it's a huge increase in the numbers
of electrophysiologists.
Yes,
you know?
yes.
I mean, in a country like India, and then the people have been performing such a complicated procedure. I'm really pleased to hear that.
Yes.
Are you presenting something in this World Congress of Cardiometabolic meet tomorrow?
Yeah, I actually presented one of the complicated, complex issues of electrophysiology, and that is this life-threatening condition called ventricular tachycardia storm.
It's called VT storm, you mean?
It's called VT storm. If you are asked to describe what is VT, it's the most malignant form of rhythm of the heart. If treated not emergently, it might lead to collapse of the patients and probably the loss of life. That is the rhythm which is behind the most of the sudden deaths or the sudden cardiac deaths. Well, a patient could be lucky if he develops a VT inside the premises of the hospital, or if he is nearer to, for example, an external defibrillator, which we are all trying to place them in, at least in some public places. So if a person has a ventricular tachycardia, if not treated, I think he may actually develop into very, very fast and a rapid rhythm. And unless he is shocked or unless he is given some medications, he may not survive. But my particular topic was beyond this, and that is, even if the patient were to survive, because he was fortunate enough to be by the side of the physician with all the resuscitative measures available, and if he is given a shock and if he is revived, well, what happens late? Well, most often they will remain in the stable rhythm for at least a considerable period of time. But my topic revolved around that particular clinical situation where you revived once, but within no time, again he gets into this malignant arrhythmia, and then again he is given a shock. He revives, then again he develops. So it's like a recurrent requirement for the shocks. Maybe the chest may get charred because of those shocks. So this is the scenario, what we call a VT storm, and that is what was the discussion we had. A wonderful meeting, and large number of attendees, lot of interactions, well, it was pleasant
Well, I must say
to
that
be.
it's a very well organized meeting, and then the number of the turnout and the crowd, the enthusiastic crowd,
Absolutely.
was really, really amazing.
Right.
Well, then tell me more about the etiology. What do you think? What could possibly cause this VT storm? We've been hearing about the people lucky who survived the thunderstorm, and same like the people who will be lucky who survived the VT storm out of the hospital. So here we are in the hospital with none other than Dr. Pandurangi. Would you enlighten us, like what possibly can cause this?
Yeah. If you look at that data, for example, who are the people who were fortunate enough to be there inside the emergency room or in the presence of a cardiologist with all the emergency equipments available, and then who have had these kind of a recurrent ventricular tachycardia and then requiring a recurrent shocks? Well, you are now talking about in-hospital data. Yeah, you probably will not be getting the true incidence of such episodes outside the hospital premises. But if you look at the in-hospital data for the VT storm, of course, the commonest cause is the coronary artery disease. It is the heart attacks. It is the myocardial infarction.
Yeah.
So it is the commonest cause
Yeah.
for patient getting into again and again into a very serious rhythm disorder, and that is VT. Fortunately, even though it happens to be the commonest cause of a ventricular tachycardia storm, we have effective means by which you can bring down this storm. You can calm the storm by quickly giving certain medications which will open up the so-called clogged blood vessels, or if the facility is available, you can do percutaneously without an invasion called an angioplasty and bring back the restore the blood flow.
Yeah, well, I totally agree with you. Despite of all those things, you still see that the tissue becomes scarred and fibrous, and then let's see the trigger of it.
Right.
Yeah.
Right. So when it is commonest, and fortunately the storm comes down, if you achieve the blood supply to the affected area,
There you go. Yeah.
there remains certain percentage of these patients, and that
Absolutely
is
right.
also the most difficult VT storms. Well, my talk, even though it covered what are the other causes, actually the discussion went around, this is the subset, how do you achieve the calm of the storm?
That's the thing. How do you calm the storm?
Yes, this is most difficult, and in the best of the centers, patient surviving out of this storm is just about 20%. But how do we manage to at least make those 20% of the patients to survive? Include certain basic treatment modalities, that is to sedate the patient to an extent that you might have to make him to undergo general anesthesia.
Oh, really?
Right, because the so-called anxiety that is associated, what we call sympathetic surge, has to be brought down. That actually is the mainstay of calming down the storm, bring down the sympathetic surge by maximally tolerated what we call beta blockade. That includes sedation, general anesthesia. Empirically, you can make a cocktail of certain drugs like lignocaine, amiodarone, mexiletine, procainamide, all these kind of medications, because you are so desperate, something may actually hit.
Yeah.
And then one of the models.
Will that be wrong to say that the VT stroke is not only because of the scarred myocardium or electrical dyssynchrony? It may be sympathetic overdrive as well.
Yes.
Yeah.
So
there's an element of the sympathetic
that becomes the main cause for some other VT storms. When we are discussing about this commonest cause is the so-called heart attack.
Yeah.
Here, of course, sympathetic surge, and then with all these medications and intravenous injections, the one thing which needs to gain popularity, and that is actually a simple technique, and that is what I highlighted today, and that is known as a temporary stellate ganglion blockade, by injecting some local anesthetic into the neck where lies a ganglion which actually is actually, if not initiating, but helps or causes the perpetuation of this arrhythmia.
And so it is difficult to localize a sympathetic ganglion, or do you do some kind of radiological guidance kind of thing?
Yes.
How do you localize? How
Yeah.
do you convey the message to the people who are not probably EP
Right.
trained?
I want every physician who actually takes control of the emergency rooms
Yeah.
or the so-called critical care units
Yeah.
has to learn this technique, even though these cases do not come by every day.
Yeah.
But once they come, this particular technique is going to save lives. When it comes to the skills that is required, well, every intervention requires skill, but this intervention does not really require a high standard of skills here.
Yeah.
It is just like to palpate some of the vessels here and palpate one of the tubercles of a vertebra without any guidance. That could be all right, but then the best way, well, it can be a little more technically challenging, and that what we do in our institute
Yeah.
regularly
Yeah.
is something known as a ultrasonogram guided
That's it.
structure.
Yeah.
You can easily identify even the ganglion, and then an ultrasonographically guided needle, if it is projected towards that, well, most often you are going to get gratifying results.
So as long as you're away from the carotid vessels,
Yes,
whatever
it's
the
safe.
structure, it is a ganglion.
It's
and
safe.
e-
It's
and
safe.
even if you're within the vicinity of the ganglion, you're still okay to go
Right,
for it.
right.
That's a very
Well,
good message. Yeah.
Yeah. So this I want to be learnt by every single physician in the ER to learn something known as percutaneous stellate ganglion blockade. Left side to
Yeah.
begin with. Storm continues, maybe right side.
Yeah. So
People-
start with the right first or left first? Which would you
left
prefer?
first,
Left
because
first and
we
followed by the
consider
right. Yeah.
the heart
Yeah.
has got more innervation of a left-sided sympathetic input.
So I'm really getting excited to learn more about the VT ablation. So we have learned about the medication, number one. We have learned about the sympathetic ganglion denervation, and then the third, I guess, will be your ablation.
Exactly.
With Ulhas. And how-
Unfortunately, in
could
the
you just
country
walk
like
us through about the ablation process, please?
Yeah. So I think if you ask me, when you do all this, you can actually double the survival rates.
Really?
If your institution has this electrophysiologist or a electrophysiology facility.
Yep.
Because the data shows that if you can take up these patients for an emergency procedure, the success rates are going to just double without this.
Which is very, very promising, isn't it?
Right. That is what we call as, the ventricular fibrillation induced by some of those ectopics arising from particular region of the heart, what we call vesicle or a Purkinje fibers.
Yeah.
The localization of vesicles in the Purkinje fibers,
Yeah.
It is not technically very challenging. And then if you really see some of those ectopics triggering this,
Yeah.
and then, one or two burns at that particular spot in front of your eyes,
Yeah.
the storm just calms down.
So do you go the 3D guided mapping, or you just go the electrically guided mapping? Which one you prefer?
Right. I think in such an emergency situation, if you do it just with the traditional fluoroscopy and the electrograms, I think it is tough to hit upon the storm. If you got a three-dimensional electroanatomic mapping system in your institute, well, this actually might turn out to be a simpler ablation than what you usually do in
the
day-to-day.
conventional those
For
days.
example,
Yeah.
pathways
Yeah.
or some other, atrial fibrillation, for example. So arduous, so very difficult. But here you just get inside the heart, target the sites of those ectopics, and you are done. It is just
Well,
that.
I find myself in a very complex situation. One hand, I have got the emergency patient who's having this kind of VT stroke. At the other hand, I'm kind of preparing the patient for 3D anatomical mapping and then putting the catheter all at the right place. So I initially, when I was doing my training, I found it so difficult. Why I'm doing all those things? Why can't I just go for the electrical mapping, straight away go to the point and burn it? But later I realized it's always good to have a guide map. You correct me if I'm wrong. Would you prefer to have a guide map, which is the 3D mapping, as opposed to only the electrocardiographic mapping system?
I always consider both the things
Together.
require.
Yeah.
Each one is indispensable of the other. Or it is going to be the information derived from all the imagings, all the electrograms. Yeah. So I
I think
strongly
we both are in the same discipline, and then I think if we go on and on, there will be never ending. I guess we have to summarize our things in just 2-3 sentences. What would the message you'd like to give it to my local people and the local physician or general cardiologist?
Right. See, ventricular tachycardia storm or a VT storm is not a very, very common entity as compared to any other diseases what a physician, comes across. It is one of the rare entities. But then it carries, I think, the highest immediate mortality. So that is why it gains so much of an importance. If an emergency doctor has this condition called VT storm in his patient, well, he should quickly be asking for other team support. Resuscitative measures are there, sedation, deep sedation, anesthesia, a cocktail of antiarrhythmics, shocks, stellate ganglion, maybe epidural anesthesia, and then if he is lucky and in his institution there is an active electrophysiology lab, and then radio frequency ablation.
Send it to us for radio frequency ablation.
So that's the
that's the crux of the message. That's very, very kind of you. You have summarized it very nicely. So the medicine first, stellate ganglion innervation, then anesthesia, and then for ablation. That's a perfect summary. It was really a pleasure to have you, Dr. Pandurangi.
I'm honored to be with you.
Thanks a lot.
Thanks so much.